You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for December 18th, 2020. This week, COVID good news, sacubitril, valsartan, and spironolactone use in heart failure with preserved ejection fraction, and a year-end review and some comments. First, an announcement. Christmas and New Year's this year both fall on Friday, so This Week in Cardiology will take 2 weeks off and return on January 8th. I want to take this moment to thank you all for listening to this podcast. It means a lot to me, and I'm grateful. I'm especially grateful to those who reached out to me this past year, whether it was in agreement or disagreement. The feedback really helps me improve the content. I also want to recognize the news and features team at theheart.org Medscape Cardiology. These are serious professionals without a hint of bias. I feel lucky to work with them. All right, first topic, COVID, of course. There's 2 nuggets of good news this week, I think. Now, I know that there are some places that have a severe situation and pressure, like, say, Southern California. But on the Johns Hopkins site, it showed a flattening of the peak in U.S. cases. And since this is a 7-day rolling average, I see it as a potential good sign that maybe the surge has eased. It's certainly eased here and is more just a steady high rate. But of course, we have to worry about the coming holiday weeks. Now, the biggest news is obviously the rollout of the vaccine. And we started with it here at our hospital this week. And social media feeds are just full up with doctors and nurses and respiratory therapists getting the shot. An advisory committee at FDA heard the Moderna vaccine data yesterday. The vote was positive, and the approval of that vaccine is likely, and soon there will be even more vaccine supply. I really think the pandemic is almost over. There is light at the end of the tunnel, but what a year it has been. All right, next topic is going to be heart failure with preserved ejection fraction. An advisory committee at FDA met this week to discuss expanding the indications for sacubitril valsartan to patients with heart failure with preserved ejection fraction. Now, recall that the drug sacubitril valsartan, which would be easier to call by its brand name, but I refuse to do that because pharma needs no help in marketing. This drug is approved for patients with heart failure with reduced ejection fraction. This was based on the Paradigm HF trial, which compared sacubitril valsartan to enalapril and found a 20% reduction in the primary endpoint of CV death or heart failure. The median EF of those patients was 29%. But heart failure with preserved ejection fraction is much more common. The discussion at the FDA concerned the Paragon HF trial. Now, I know that sounds like Paradigm HF, but it's Paragon HF trial. This was published late last year in the New England Journal. Paragon compared sacubitril valsartan to valsartan alone in patients with heart failure with preserved ejection fraction. The results of this trial are super complicated. And the advisory committee at FDA decision is a big one because there are many more patients with heart failure with preserved ejection fraction than those with reduced EF. And it's not only the numbers of these patients that makes it a big decision. Heart failure with preserved ejection fraction is far less well understood. Heart failure due to reduced ejection fraction, this is a distinct entity in which we understand the pathophysiology, and that is the reduced systolic function. But heart failure with preserved ejection fraction is this vast category of different pathophysiology and comorbidities. More often than not, managing patients with heart failure with preserved ejection fraction is about managing the patient's comorbid conditions, say hypertension that's out of control, or AFib that's too fast, or volume excess, or sleep apnea, obesity, or CKD. Sometimes heart failure with preserved ejection fraction simply occurs because of old age. viz. The heart, like the entire body, just gets too stiff. The environment that we practice in also plays a role in this decision. In U.S. hospitals, the goal of coding is to maximize degrees of illness on paper. That's not nefarious, it is the system. So anyone with a bit of indiscretion with salt or fluids who gets volume overloaded, say at Christmas dinner, now has heart failure with preserved ejection fraction on paper. Okay, that's some background now to the discussion at FDA, which was centered on Paragon-HF. This was a large RCT comparing sacubitril valsartan to valsartan in about 4,800 patients with heart failure with preserved ejection fraction, median age 73, about half female patients. The median NT-proBNP was 900, and the median ejection fraction of these patients, 57%. The primary endpoint was a composite of total heart failure hospitalizations and CV death. The choice to use total heart failure hospitalizations is notable because previous trials in heart failure with preserved ejection fraction used time to first heart failure hospitalization. And when I tell you the results, remember that the counting of total heart failure hospitalizations will accrue more events, and that should theoretically increase statistical power. Okay, the results. There were 894 primary events, that's 37.1% in the sacubitril valsartan group versus 1,009 primary events, or 42.2% in the valsartan group. The rate ratio was 0.87, so a 13% relative risk reduction, and the confidence intervals went from 0.75 to 1.01, the p-value 0.06. That's right, 0.06. The lower rates of heart failure hospitalizations drove the trends towards improvement. There was no significant differences in the harder endpoint of CV death. Now, staying true to the frequentist approach, the p-value above the threshold of 0.05 means that we do not reject the null hypothesis that there is no difference between the two drugs. And if there is one thing I've learned from doing trial appraisal over the years, it is not to have binary cutoffs of this works and this does not based on a p-value. The FDA reviewers said that, quote, the trial only missed its target by a little. Now, they dug deep into the weeds of the adjudication of heart failure events and found that if you add in urgent heart failure visits, say to a heart failure clinic that can give diuretics, then that would add enough events so as to tighten the confidence interval and slightly change the rate ratio from 0.87 to 0.86. And now the primary endpoint would be significant at a p-value of 0.04. Now, another way they could make the main trial results get over that threshold of 0.05 is to count investigator-reported events rather than what was done in the trial, which was central committee adjudication. The trial was blinded, so the FDA reviewers argued that using investigator-reported events is legitimate. Now, this analysis does not change the rate ratio of the primary events. Still, it's about a 14% reduction, but again, it adds more events, and that tightens the confidence interval, and now the FDA reviewers with this analysis can get to a p-value of 0.01. And if you use total HF events, total heart failure events, including urgent visits and investigator-reported heart failure events, you get to a rate ratio of 0.83 and a tighter confidence intervals and a p-value of 0.006. The FDA reviewer's quote was this: the study failed to reject the null hypothesis for the prospectively planned primary efficacy endpoint. However, reasonable exploratory analyses, planned and unplanned, were able to reject the null hypothesis. Still, though, there was no change in the null effects on CV death or overall death. But that's not all. There was even more to discuss. Now to the subgroups of Paragon-HF. Recall that when Paragon came out, there was much discussion of subgroups within the main trial. The question being, were there groups of patients that did better? A large chunk of the discussion at FDA focused on the possibility of a heterogeneous effect in two subgroups. One of these was female patients, and the other were patients with EFs lower than the median of 57%. So in the New England Journal paper, Figure 3, we see that female patients had a 27% risk reduction in the active arm, But male patients, the rate ratio was 1.03, and so no reduction at all. The authors also separate out events in those with a median EF of less than 57% and those greater than 57%. And in the lower EF group, the rate ratio was 0.78, so a 22% reduction. But in those with an EF greater than 57%, the rate ratio was absolutely no reduction. So at the FDA meeting and on page 49 of the document, they combined the two subgroups and looked at the rate ratio for female patients who had an EF less than 57%. And for this subgroup, there was a massive 43% reduction with the drug. They also cited a prominent paper from Paragon and Paradigm authors which combined the two trials looking at valsartan sacubitril's effects across the spectrum of EF in the two trials. This was published in Circulation in February, and I'll link to it. Figures 3 and 4 from that paper show that the drug has its greatest risk reduction at an EF of about 30 to 45%, and the benefits seem to extend to higher EFs in female patients versus male patients. So in sum, then, we have a trial that did not meet its primary endpoint, but there appears to be subgroup effects. The FDA committee voted on the question. Here's the question. Does Paragon HF, perhaps supported by previous studies, provide sufficient evidence to support any indication for this drug? 12 voted yes, 1 voted no on the question. Okay, so 3 big comments here, and I'm working on putting together a formal column on this because I think it's important. Number 1 question is, the effect size worth the cost? I mean, Paragon HF is a best case scenario like most trials, right? Big trials recruit at good centers, places that have research nurses, and patients in these trials get excellent care. The trial has a run-in period, which again helps select a group that tolerates the drug. There are no run-in periods in real practice. So in this best case scenario, the costly new drug did not look much better than a generic alternative. Yes, it was close, and reasonable analyses can get over that threshold, but remember, there was no difference in CV death in a group of older, sicker patients. Heart failure with preserved ejection fraction confers a similar prognosis to patients with heart failure with reduced ejection fraction. So I would ask, if valsartan sacubitril is so great, why can't it reduce CV death or overall death? And another question, can a society afford to pay for an expansion in the use of this costly drug to such a vast group of patients? Second comment is about subgroups, and here it is wise to revisit the ISIS-2 trial, which I've previously mentioned on the podcast. ISIS-2 was an RCT of streptokinase aspirin, both or none, after MI, and it was done many, many years ago. Aspirin significantly reduced MI and stroke, but the Lancet editors wanted to know if there was any subgroups that benefited more or less from aspirin. Now, investigator Dr. Richard Pito tried to say, no, we're not doing subgroups because of the basic principle that if you look at a lot of comparisons, some will be significant based on random chance. But the Lancet editors insisted. To show the editors how chance findings can occur in subgroups, the authors subdivided the findings into 12 subgroups according to the patient's astrological birth sign. I know, it sounds crazy. But the results in each of these were then examined to find which of the 12 appeared least or most promising. And it was discovered that aspirin appeared totally ineffective for patients born under Libra or Gemini. Now, I know that's crazy, but it does show how chance findings get into subgroups. I went back and looked at the subgroups of Paragon HF and also found that patients in Western Europe had a 31% risk reduction with valsartan sacubitril, but all other subgroups of patients from other areas didn't have any significant difference. So if we use the logic of using the drug in females or those with a median EF of less than 57%, why wouldn't we restrict use to those patients in Western Europe? Another subgroup finding that stands out was that patients on MRA drugs, mineralocorticoid receptor antagonist drugs, had a 27% reduction versus a non-significant reduction in patients not on MRAs. Again, should we restrict the drug to only those patients taking MRAs? And so what if we did a similar analysis on astrological sign from Paragon HF? You see the problem with subgroups. Now, third comment about Paragon is the implications of approval. If the FDA takes the advice of the AdCom, I'm afraid of what will happen. In a perfect world, a clinician could use an approved drug on a selected patient if he or she felt it would be beneficial. And we do that now for inexpensive drugs. Think beta blockers for palpitations, for instance. But here in the U.S., we don't practice in a perfect world. We practice in a very bureaucratic, regulated system. And valsartan sacubitril is quite costly, especially without insurance coverage. And there won't be any insurance coverage unless there is an FDA-approved indication. So if the FDA approves this drug for such a broad class of patients, I worry that it will get into guidelines. And if that happens, then the drug's use could be deemed, quote, evidence-based practice. The next step might even be codifying its use in performance measures, like I discussed last week for atrial fib. Here's the problem with all this therapeutic momentum. Most patients with heart failure with preserved ejection fraction are elderly and have multiple comorbid conditions. The biggest impediment to valsartan sacubitril use is low blood pressure. This complication can be devastating in vulnerable patients. Dr. Julia Lewis was the sole dissenter of the AdCom vote, and I understand her thinking well. But we have to prepare that the drug will likely be approved, and it will be up to us to use it wisely, and perhaps hope that the guideline writers are very calm and wise in their choice of words in the guideline document. Our next topic is also on heart failure with preserved ejection fraction, and it considers spironolactone. And it was also at the FDA this week, the same advisory committee considered a formal label for adding spironolactone in patients with heart failure with preserved ejection fraction. The debate here centers on the controversial TOPCAT trial, which was published back in 2014. TOPCAT was spironolactone versus placebo in patients with heart failure with preserved ejection fraction, about 3,400 patients, and a primary endpoint of CV death, heart failure hospitalization, and cardiac arrest. The results with 320 patients, or 18.6% in the spironolactone group, had a primary endpoint. 351 patients, or 20.4% in the placebo group, had a primary endpoint. The hazard ratio there, 0.89, so an 11% reduction. Confidence interval 0.77 to 1.04, and the p-value 0.14. So this 11% reduction was modest and not close to making the statistical threshold of 0.05. So we do not reject the null hypothesis of no spironolactone effect. But that's weird because lots of doctors use spironolactone in patients like this. I even call it my secret weapon and use it often in the scenarios when people are struggling to control symptoms with loop diuretics, obviously with the caveat of watching creatinine and potassium closely. The journalist Patrice Wendling gives an absolute clinic on how to write well and explain the nuance of TOPCAT in her coverage of the AdCom discussion. The issue with TOPCAT is that about half the patients were recruited from Russia and the country of Georgia, and these patients were serious outliers relative to the other patients. Event rates were also substantially lower in Russia and Georgia than in the Americas and in previous heart failure with preserved ejection fraction trials. That suggests that many of these patients may not have had heart failure. In the Americas in TOPCAT, results for the primary endpoint favor spironolactone over placebo as 10.4 versus 12.6 events, and that p-value was 0.026, whereas the rate in Russia and Georgia was much lower than in the Americas and it slightly favored placebo, 2.5 versus 2.3. Even worse, the trial is published 3 years later, in 2017, also in New England Journal of Medicine, a research letter in which they showed that 30% of patients in the trial from Russia and Georgia who were randomized to spironolactone did not have a spironolactone active metabolite discoverable in their blood. The question, therefore, is, do we take the advice of the trialists and cut those patients out and accept the positive results of the group from the Americas? Panelist Stephen Nissen disagreed. Get this quote. If the pharmaceutical industry came to us with a study like this and said the p-value was 0.14, but we think a bunch of our sites weren't very good, and so we're going to throw those data out and just look at the sites we like, the FDA would not even have brought that before us. He said, "I cannot hold other sponsors, including our own government, to a different standard." The committee ended up voting 8-4 on the question that TopCat provides sufficient evidence to support any indication. I like this discussion. TopCat is worthy because we get into the weeds of trial interpretation and trial conduct. But I think the AdCom decision in the spironolactone case is going to be less influential than it is in the valsartan sacubitril case. That is because spironolactone is inexpensive and there's years of experience with it, and doctors have gotten used to using it. I actually think spironolactone is underused. That said, I'd hate to see anything mandated in performance measures for the same reason I mentioned above, that heart failure with preserved ejection fraction is this vast category, and the care of these patients requires sound clinical judgment. Algorithmic care is not your friend in heart failure with preserved ejection fraction. I actually think the new non-steroidal mineralocorticoid receptor antagonist finerenone that I've discussed in previous weeks looks very promising. Okay, year-end recap. I've written my usual year-end recap on the top cardiology stories. Doctors Bob Harrington and Mike Gibson also have their year-end discussion of the top trials of 2020. It's an excellent discussion. My piece isn't just about trials, it's more a recap of what I feel are the most important themes of 2020. Take a look and see what I missed, hopefully maybe even leave a comment. Now the new valve guidelines. I saw yesterday that the AHA and ACC have published new guidelines on valvular heart disease management. There were some provocative recommendations regarding TAVR, and I need more time to investigate it. We'll discuss that on my return after New Year's. So that's it for this week in cardiology. As always, I'm grateful that you listen. Thank you. And remember, friends, if you like this podcast, please take the time to give us a rating or even write a review. That helps other people find us. Until next year, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.